It's my great honor to welcome Dr. Claus Jensen, the Chief Digital Officer at Memorial Sloan Kettering Cancer Center, who will take us through first his keynote speech on the digital transformation age, followed by a panel discussion. And of course, I'll ask Ransel to introduce his panelists colleague. With this, Ransel, welcome again, and the floor is yours. Thank you.
Thank you. I think we'll look forward to hearing from Claus at this point. So Claus, I'll turn it over to you and then give you the honors of introducing your panelists.
All right. I'll introduce the panelists in a sec when we get to the panel part. And I'm not going to do a big keynote speech, but I thought I would share one slide, if I can find it. Hang on. There you go. So you should now be seeing one slide in my PowerPoint. Are you seeing it?
Yes.
So how do you introduce this notion of the coming of the digital age? The previous panel talked a little bit about, hybrid integrated care models, and that was not a setup. I promise I had not heard the prior panel before I selected this one slide. This is actually a slide that I've used very recently with senior executives. Right? As we went through second quarter, the question comes up to say, what did we learn? What did we do? And what do we need to keep? There was a comment that said digital first. I don't know whether it's digital first or whether it's hybrid first. It sort of depends on the scenario, right? Because sometimes you meet people in person first, sometimes you meet people on digital platform first. But here's a selection of what Memorial Sloan Kettering did in the second quarter. We went to 20 times the pre-COVID-19 scale of telemedicine. That was on the tools we had, right? And now the question becomes, are those tools actually adequate for what we really need to do? We doubled down on having an app on portable devices for secure communication on our floors inside the hospital, so that you can find people no matter where they are. Or if they're at home, you can find them there as well. We used AI analytics to get better at understanding who's the 24/7 care team without people having to put that into a system somewhere. One of the things we found was that it's not just about the clinical team. There's a whole lot of non-clinical support staff that goes into an integrated care model, and it works differently when you have to move to a hybrid model and people all of a sudden aren't sitting right next to each other in the clinic. We had a number of patients that we had to send home. This is not unique to MSK, but think about the combination of cancer and the virus and how did that work, and we didn't know. So we were a little uncomfortable sending people home without actually having real-time telemetry from the home. So we sent them home with pulse oximeters to monitor that. We tried to take some burden off of the physician's hands by digitally scribing from dictation into notes. We determined that we had a need to reach more people that weren't necessarily our patients. This was caregivers, but also just people that were scared, concerned, and wanted to have a conversation about cancer and what's happening with the virus and all that. You can't do consent the way you normally do if you're not actually physically in the same environment. So how do you get electronic patient consent and make that an integral part of the integrated care model? And there's a whole bunch of stuff around supply chain and what can you do with data analytics. So the real point here is that whether we were or weren't, many of us were moving to hybrid integrated care models before the pandemic. We certainly are in the aftermath of COVID-19. And in many ways, this notion of the coming of the digital age is all about how you can power hybrid care logistics. There is a research component. We might have time to talk a little bit about that, or we may not, depending on how the panel goes. But I just want to share a perspective that says this was one quarter for one provider institution. And I will guarantee you that no matter what large provider that you're looking at across the entire world, not just in the US, they went through something similar in one quarter, and we now all face the question, now what? We stood up what we had to in the first half of the year. In the second half of the year, trying to figure out how does a integrated hybrid digital and clinical and physical care model actually work? So on that note, I'll stop sharing. I'll go back to my panel participants, and I'll ask Dr. Affan to introduce himself and talk a little bit about, so how does digital, in your opinion, play a role in new models of care? And in particular, as we shift from inpatient to outpatient and at-home settings?
Yes. Can you guys hear me?
We can.
Okay, thank you very much. And thank you for inviting me to be part of this group and discussion today. My name is Dr. Ashraf Affan. I'm a pediatrician based in Jacksonville, Florida. I run a pediatric practice that's fairly large. We have around 45,000 patients. We are part of an HIE, which is Health Information Exchange for the entire state of Florida. So let me shed some light quickly on why did we need to be on this? Like, you know, what brought us to need the digitalization and how did that evolve? The healthcare, as we all know, is been escalating in cost, around 7.5 trillion annually in the entire world. And, you know, and half of this is being spent in the United States. We are responsible for around $3.5 trillion. Unfortunately, we had a lot of waste because of the redundancy, because of not, you know, doing any interoperability from before. So the need to get into digitalization, the need to get into containment of the cost together with improving the quality was the main goal of, or the main reason why people moved to look for some quality of care over the quantity of care. So when this comes to the digital and the role of digitalization for doing this was very importantly that if we can shift the care from tertiary, more expensive care with all the consequences of you know, leaving patients in the hospital unnecessarily to more going more towards prevention and going more towards primary care, but at the same time, we did not want to compromise the care for those patients. That's why by having some monitoring devices, having the follow up with the digital abilities for those providers, they can safely send those patients early to their homes and monitor them if in case there is need of any intervention to be done. So this is how it's helping us. And, you know, doing this in my practice has cut a lot of costs for us. And I think we were down by 33% for our inpatients care. We were able to cut this without compromising the care for those patients. Actually, they are very happy that they are continuing to get care at home and yet being monitored and being very confident that if anything happens, they have a provider who can follow them up.
Tim, I know you spend a fair amount of time thinking about telemedicine in particular. Would you care to introduce yourself and give us your perspective?
Sorry, Claus, you're talking to me?
Yes, that was for Tim.
Yeah, okay, sure. Thanks so much. Yeah. So my name is obviously Tim Kelsey. I work for HIMSS. I'm in charge of all the global operations to help health providers assess their digital maturity in health systems outside of the US. I'm based in Sydney, and I was one of the co-founders of something called the Global Digital Health Partnership, which now has about 30 countries and the World Health Organization looking at collaboration around digital policy internationally. And that was started in my role at the time as the chief executive of the Australian Digital Health Agency. So yes, so telemedicine has a particular pertinence in a country with a geography like Australia, and was very widely kind of available in advance of COVID, very remote communities benefiting to some degree from clinical engagement with some fairly basic infrastructure. But the volume of episodes of care that were amenable to telehealth that were actually being transacted using virtual means amounted to roughly around, on most people's judgment, around 0.1% of the episodes of care that could have been delivered by telehealth. And what, of course, we've seen as elsewhere in the world is that in the last, since COVID has occurred, a dramatic acceleration of the use of telemedicine. And broadly speaking, about 80% now of those episodes are conducted virtually in a way that wasn't true 6 or 7 months ago. So an enormous, vast acceleration in the momentum behind digital health. But if I may, I might just give one piece of context in Australia. Australia, of course, had been, like many countries, very focused on digital health, hence the establishment of the agency, of which I was the inaugural chief executive, because of the evidence, increasing evidence, that it supported significant improvement in things like reductions in medication error. And 2 years ago, the Australian government introduced a reform which I think has real pertinence in the current situation, which I'll just very quickly describe. The idea was to give patients access to their own medical information, at least in summary form. And for some years, a program called My Health Record had been available on an opt-in basis to people in Australia. And this provided them with access not just to summary information, but in fact, in some cases, to comprehensive medicines information, pathology and radiology. The evidence was that the clinical community was only really likely to engage with such a infrastructure if it was ubiquitous, if more or less the clinician had the expectation that in pretty much every consultation a person would have a My Health record, and therefore it would become something that was routinely used by the clinical community. And because it provided access to medicines information in real time and similar clinical information, it would hopefully mean that the incidence of medication misadventure would be reduced and prescribing error reduced. As a result of which, the government took the decision to go to opt out on My Health record and essentially provide it to every citizen unless they chose not to have one. And that was my task, was to introduce opt out to Australia for this digital infrastructure. That occurred successfully last year, and now about 90% of Australians have a My Health record. Now, the prescience of Australia in introducing that reform just ahead of COVID, of course, wasn't known clearly to the politicians and the team in my agency that did that. But I think what's important about My Health record is not only that Australia is one of the few countries that now has a national infrastructure that allows real-time medicines information, pathology and radiology to be available pretty much for every citizen to every treating clinician in real time 24/7. But this is on the basis that the patient has the ability to decide who sees that information. And it's at the patient's discretion that the clinician is able to view that information. And I think this is a very important basis for us thinking about the future of digital health post-COVID, is on what basis do we reflect that the power to decide who sees this critical clinical information is actually made. So I just put that out there as a thought starter for this conversation.
Thanks, Tim. I mean, one of the things that we saw, and you sort of hinted at it, is that this notion of remote care is a lot more than the televisit. But that's the part we talk about. And there's all these tools that we need to get out there. And people have used everything from, WebEx, Zoom, Teams, etc. But what you're calling out is really about the integrated process end to end. So, Olivier, I know you have a perspective on that, and in particular, the end-to-end integration. Would you care to introduce yourself and chip in?
Yes, good morning, good afternoon. I'm Olivier, Jarry, coming from big pharma and big devices. And as an engineer, I moved naturally to digital health, starting 10 years ago. 10 years ago, I was managing diabetes. We introduced the first blood glucose meter with a USB-A connection, which at the time was revolutionary. And look at what we've done in the last 10 years. Look at what we've done for 9 years, improving connections and connectivity. And obviously in the last 6 months, so much on telehealth and these areas. There are probably 3 different things that we are putting together. One is really telemonitoring, which is capturing data either entered manually by the patient or entered by devices. One is the dialogue between the patient and the practitioner, which is really telemedicine or telehealth. And one is digital interventions that actually the patient can have with their own device and their own system. And I think we are going to cover these 3 aspects and how they integrate together in the rest of the panel. Maybe let me take a slightly different angle and say what remains to be done, because we all are very happy in a way that things are moving fast, and in the last 6 months, 1 year, there has been a lot of progress, but there is a lot that remains to be done. I think on the previous panel, Derek insisted on the fact that we have to develop different competencies, and we have to work differently than we used to work. I mean, everybody does it from home and so on, but as a medical practitioner, that's probably even something more of a change. But there are other areas that we shouldn't underestimate. One is quality. What is the quality of the device, the quality of information that you are having from digital health, and is it enough, or is it does it make you take additional risks or assumptions that shouldn't be made? So the quality topic, I think, is still something that everybody is still working on. There are things that are easy and that's fine, but obviously some things are more complicated. Second is regulatory. There has been a lot of changes, again, at least in the US, for the approving telemedicine, telehealth applications that would not have been approved so easily a few months ago. Is it going to reverse in the industry? We are a little bit looking at it and say if this is reversing and then we are losing this facility of using telehealth, that will be damaging, because we are getting used to it and it's really, really useful. And how regulations are going to continue evolving to allow for it. And obviously many people are working on it. And the last piece is reimbursements. Reimbursements means that you, the payers, have to look at things very differently. And that's where we have seen the most inertia so far. Again, the US is a little bit more advanced on the public side, the private side. Many other countries are still struggling with reimbursing digital health. One of the aspects is payers are used to pay for service. And you see the service, somebody passes the door of an office, they stay half an hour, they get XYZ codes, and this was the service, and they are billed. Now, if you are not seeing the patient the same way, are you paying for minutes on telehealth? Are you paying for actually performance and outcomes? So what I wish is that we are going to move even more to pay for performance. That is absolutely what telehealth and telemedicine can do. But I think the payers still have to work on it.
You touched a little bit on data. Would you care to comment on the role of longitudinal data in health ecosystem integration? It's the Holy Grail. I mean, our ability to put together multimodal data from different care settings and different types of engagement models. But it's also a really hard problem.
So let me start on this one. This is a topic of this is partially the topic of interoperability. That was the subject of a president's speech a few months ago in the US. It's absolutely essential, and it's extremely difficult. And we are in an area where there are few standards and norms. It's already when you are a provider of services and you start to interface with a hospital, what we used to say is there are not two Epic installations that are the same. So you come to this hospital, they have Epic, great, and then they work differently than anybody else, and then you have to spend months to reintegrate with this new system. So it's something that obviously has been treated in other industries. I'm actually coming 30 years ago from aerospace, where there started to be international norms and interfaces, and we had to fight to get to stop plane inspection on paper and move plane inspection on electronic records 30 years ago. We are at this point now with medicine, and we are probably a little bit behind in the sense that we have much less normalization of interfaces and data that is absolutely essential. So probably what we'll see in the coming few years is what we used to call middleware in other industries, which is connectors that try to make sense of all of this disparate data and try to push it into your system. And hopefully once things stabilize and standards are emerging, then we don't need middleware and we can connect things directly.
Dr. Affan, the same question for you, your take on longitudinal data and health system integration.
Yeah, thank you. I think this is really very essential. I want to just tell you how we are currently using this among our 45,000 patients, as I mentioned. We pull data from our electronic medical records, and we are part of the HIE for the entire state of Florida that gives us some real-time messages for patients. When one of our patients is in the emergency room, we get a notification immediately that we can either communicate with these patients, or actually when they get out of the hospital, we do some education, we do some communication to follow up. So the analytics is really very important in that term, that when we pull all those data and we kind of, make use of this data, it helped us in a couple of things. We can measure the clinical quality for those patients. We score very high in all the pediatric measures for the quality because of the analytics and because of how we are utilizing this data. Also, we are able to educate both our patients and our providers. In terms of patients, we are able to educate them on how to use the healthcare facilities very wisely, and when they need to be in a hospital, when they don't need, when they have a good access to our primary care facility. And also we educate our providers to be able to, in terms of, using formulary medications, for example, not to be out of the way for any protocols for care or guidelines for care for those patients. And the end result of all of this has been tremendously helpful. Without this longitudinal data analysis and usage, we wouldn't have been able to get into those purchase of the value-based or pay-for-performance, which we have 3 big contracts, and this sustained our practice during this pandemic. If everybody knows that, all the healthcare systems have been suffering because of lack of operations, lack of selective surgeries or elective surgeries and visits to any doctor's office. On the contrary, in our case, because of those underutilizing the service funds and our contract with the insurance companies, we were able to collect some good funds and payments, and it did work very good for us.
Thank you. And Tim, is this easier in Australia, or do all countries have the same kind of challenges with longitudinal high quality data integration and how you put all the pieces together?
Well, it's such a great and important question. So the answer is, I'm unaware of a single country that has solved this problem. I mean, the closest we've got is some of the Nordic countries are close. You could argue that Estonia, Denmark, Sweden, perhaps, certainly southern Sweden, are now in an almost fully interoperable state where genuinely they have linked data across the whole pathway of care, and they are able to track a patient through their entire care experience, allowing for predictive analytics of a kind that we all talk about, we've been talking about for a decade, but actually can more or less happen in Denmark and Sweden. But these are relatively, I'm not in any way underplaying the achievement, but these are relatively small countries where, to be honest, I think culturally there's more trust in government, and the consenting process, for example, in Sweden is one in which, and Denmark is one in which essentially you just don't get healthcare unless you agree in effect indirectly to let your data be used for analysis. And when you come to Australia or the UK, where I previously worked for the National Health Service, you have a much more complex environment of social license and expectation, combined with some really very real technical challenges, which I think are endemic across the world. And one of the reasons for the foundation of the Global Digital Health Partnership. And we just think, for example, of identity. We still don't have in most countries genuinely a single patient identifier that is used primarily on clinical correspondence, and that enables interoperability of that patient's information across all their care pathways. That's just one example that stops the ability of longitudinal analysis through linked databases. But another equally important one is semantic interoperability. So although some great advances have been made in the use of SNOMED CT in many countries, it's still essentially an orphan standard, which we're all pushing to promote. But without the use of SNOMED CT, in my opinion, we're going to find it extremely difficult to reach kind of the space we all want to get to, which is of an interoperable healthcare system that does allow for fully integrated data analytics and predictive data management. And I think the third challenge, I'd be interested in what other panelists have to say about this, that almost all countries I have experience of share, is the absence of what you could loosely call a service directory. In other words, a simple national directory of the clinical providers that exist and where they work, that in real time is able to track movements and so enable you not just to track benignly the outcomes patients may experience at their treatment, but also to track the doctor's own practice or the clinician's own practice across the longitude of the service. So those are just some, I think, of the challenges we've got, which are very much in common, very real. The great news is that in the last few years, these have really come into focus, and there's been a lot of collaboration globally to try and work out how we might solve the problems that we all face. But that is still a very real problem for enabling longitudinal analysis.
Denmark is an interesting case. It's my country of birth. It's a system that I know particularly well. I lived in Denmark until 12 years ago. And Denmark does have, to point, this notion of a global identifier for the country, and that helps. But interestingly, even though it's a government-run system, about, what was that, 15 years ago, 10 years ago, I don't remember the exact date, right, when Denmark was saying, so what is the new platform for the electronic medical record? Actually, 5 regions went out and built 5 different systems. Yeah. And you'd think that in a country of 5 million people, and it's like not that big geographically, maybe everybody could agree on one. But I think, to your point, we've seen even in government-run systems, for some obscure reason, it ends up with having multiple. And now you have to do some kind of brute force integration. Your point about the service directory is an interesting one. I mean, Denmark doesn't have one, I can tell you that. Australia doesn't have one either. Olivier, your perspective on the importance of a service directory. I think we've all tried to use Google or our various, health insurance portals to try to find a doctor. What's your take on that?
That's the general topic of where do you find your information about health in particular, and about providers in specifically. Everybody has been trying to work on this. Everybody has been trying to make sure that there were portals that you can trust for your information, for your provider data, for your provider rating. Many countries don't like to have the providers don't like to have a rating as well. In some places it's allowed, and sometimes even encouraged. I think the main thing is that people can be in a system of trust, and I think that Tim mentioned it for Sweden. I think government a few years ago said something to the tune of, "We take care of you, your data is ours." So this probably would be extremely scary in some countries like the US, but the fact is, when you can trust the system, when you can trust a directory, a register, a source of information, and that things will be kept confidential, that changes everything. So I think beyond the directories that are more or less available depending on the places, it's more where do you find your health information? Can I trust this app? Can I trust this website? I think in an era of disinformation and all kind of noises, that will be even more difficult on the health side to make sure who you can trust and what information you can trust.
Disinformation is an interesting point, right? Because if you go to many of the public sources, it's very hard to figure out what is the veracity, the actual solidness and quality of the information you can find. Certainly the case in what I think we all use, which is Google. So, Dr. Affan, do you have a perspective on how do you get to quality information about what services are actually provided and where you should go? It's a very hard problem.
Okay, sorry. Thank you very much. I think I do agree with other people about who do you trust. The security is really a big issue for everyone. How can I make sure that my data, whether I'm a provider or I'm a receiver for the service, this is actually an issue for us. As far as even advertising for ourselves, for our services as providers, we kind of find some difficulties. The interesting news is I've been following some data about some ecosystem that are using the blockchain, and the blockchain is really interesting, that the security of the data and how people are sharing those data and flow of the data and information for the providers and the receivers of the services. I think it's going to be an evolution using that blockchain and securing this data on a national level or a regional level. This is coming to be part of the new ecosystem for healthcare.
Yeah, I mean, to a point, we don't really have an information highway for all things health. Blockchain is an interesting technology, and it could certainly beat a record, but that would be premised on millions of provider systems being tied into the same blockchain with the same trust model. I think what I've found as I've sort of gotten immersed in healthcare, and I've been in healthcare for about 6 years, both on the payer side and on the provider side now, is that the longer you're in healthcare, the more you become conscious of the fact that it really is about the whole human. And it's all of the data across clinical genomic, which is a sort of the hard data, but also the environmental data, the behavioral data. There was a comment or question in the chat about the notion that it's rarely just about the single disease that you're treating right now. There's all other kinds of factors, certainly true for cancer, true for many other medical conditions. And if we don't understand the total picture of what's going on, if we don't have the integration of the healthcare system, how on earth do we get better at generating the right picture and the right insight around the patient across clinical, genomic, environmental, and behavioral data? Dr. Affan, you first.
Well, as you mentioned, this is really challenging. I want to take this and talk about in my field, immunization, for example, that the WHO just released some data a couple of days ago, very alarming data for everyone about the reduced rates of immunized children around the world. I think from 84% down to 70-something%, 11 points down. And this is really very dangerous, to your point that, now we're following one disease and we are ignoring what could happen a couple of years down the road. I'm following in Africa right now, poliomyelitis started to come back. So the question is, how can we encompass all of those things and not focus on one disease, which is like the pandemic that we're facing right now? Answer is going to be very tough, and I love to be on such brainstorming sessions where people can find a solution and find the one system that would focus on different channels rather than one place.
Tim, is there a more elegant solution? I keep coming back to, you can give us a perspective that's not US. Is there a more elegant solution that you've seen anywhere that ties together these different sources of data and maybe even puts together the medical component? That we know that there's a correlation between dental and medical, and there's even some correlation between vision and medical. How's that handled across the world? What have you seen?
Yeah, it's interesting. Well, I mean, I've got to say that in many countries, and Australia certainly is included, the one group of people who benefit from often a fully linked longitudinal data set are those who serve in the military. So, for example, those serving in the military in Australia, and indeed veterans who leave the military in Australia, by law, their data can be linked. So researchers, for example, in Australia, link the data for veterans, just to give you one example, in a program where they're able to look very precisely at the medication regime provided to individual veterans, regardless of wherever they are in the care system, link all that data together, and then be able to quite literally write to the treating general practitioner and recommend and really advise the GP on whether or not the drug regime they have that patient on is consistent with best practice. And so you're getting curated support, clinical decision support to individual GPs from a national longitudinal data infrastructure, supporting very significant improvement in outcomes because of advice being provided on best medicines practice, just to give you an example. And I'm familiar with this kind of process existing with a number of other, defense-related medical networks in other countries. So we know it can work. And one of the bizarre anomalies in a country as distinguished as Australia, for example, is in relation to healthcare, where on really any measure, Commonwealth Fund, whichever you pick, it's either the first or second best in relation to outcomes in health in the world. You've only got roughly about 250,000 out of the 25 million people in this country being provided with that full, rich service powered by really very advanced predictive analytics across the whole spectrum of their healthcare. So I think that we know it works. We just need to understand the legal and social sort of social license requirements necessary to enable that to be propelled, to be made available to all citizens in countries like Australia. So that's just an interesting example. But I think there are 2 points I'd additionally make, if that's okay, and maybe we can dig into this a little bit more. In my career to date, I have had sort of the privilege and the experience of being involved in a number of really quite controversial reforms in which the question of trust, public trust, and social license has been really a very important political consideration in developing linked data sets in healthcare. I had the experience of that occurring in the National Health Service in England, where we made a proposal to link primary and secondary care data. Turned out, as we discovered, that the legislative framework to enable that simply wasn't adequate. So we stopped that program, re-legislated. That now is occurring in England. And in Australia, a few years later, when we launched the My Health Record, we proposed that there should be a framework for using data in My Health Record for similar analytic purposes. And that is part of the program that's now underway. But in both cases, there was a very important, vibrant, positive public discourse about the relative merits of shared data, patient privacy, and social benefit. And I do think that that is a really critical priority as we begin to look forward beyond COVID, that we think about the importance of the narrative in relation to benefits of digital health being very, very clearly explained and demonstrated in order to earn the license to allow us to do the kinds of things, Claus, you're talking about, which are really extremely advanced integrated data sets pulled from not just health environments even, but from all those human contexts that make the social determinants of health. I think we need to continue to have a very important conversation in public about the ethics and social license involved in some of those objectives and their public benefits.
Olivier, from your perspective, is this a technology problem? Is it a digital problem? Or is it really, as Tim sort of hinted at, more than anything else, it's a process and regulatory problem? Do we have the technologies to fix this problem, but we don't have the setup to actually allow ourselves to do so?
We don't have always the technology, to be very frank. Let me look at it as this topic of integration, depending on the actor you speak to, payers, providers, or patients. If you look at the payer, yeah, Tim is right. The military, the NHS in the UK, Intermountain in the US, they see everything. So they see everything that the patient is doing. Remember, working with the NHS, they know what doctor, what prescription, what pharmacist. I mean, they have all the information integrated because it's the nature of things. So in that case, there is no limitation in terms of technology. It's more a question of process. How do they want to process it and how do they want to pay for it? When you move to a provider, there starts to be silos. So if your patient is coming from Utah and you deal with them in New Jersey, are you going to access the information, and how do you access the information, and do you need to recreate it, and you need to redo all the diagnostics that have been done, run on this patient, and these kind of things. It's not so much a question of technology in that case, it's mostly processes that things should be more interacting and interoperable. And then you come to the patient, and everybody speaks of empowering the patient. Is the patient really empowered now by technology? Not yet. Technology is not there yet. What we used to say in digital therapeutics is you may have an elderly with many conditions, and she can take 10 pills in the morning with a big glass of water and 10 pills in the evening with a big glass of water. She cannot take 10 digital apps. She cannot manage her diabetes on one app, hypertension, different app, depression, different app, eyesight on a different app, and so on. And there, nobody yet has a solution except a consolidation of a company in digital therapeutics, which starts happening. Everybody that has been diabetes goes in hypertension and tries to move into depression. But the one that should be served, the patient, is not yet served by technology.
So we've all given, all four of us, different examples of how powerful it would be to put all the pieces of data together. We've also given examples of how difficult it really is. I personally believe that if we could create that kind of longitudinal record, we would actually empower ourselves to not just treat people better, but we would probably also push frontiers of medical science. There's insight hidden in that longitudinally integrated data that we will never be able to unlock without it. But if we move on from the data itself to, so what are you going to use it for? You mentioned digital therapeutics. That's a fascinating area, and there are probably as many opinions of digital therapeutics as you can put people in the room to talk about it. So what's your opinion on the future of, I think, two things: digitized diagnostics, which is, can we get better at the diagnostic science through digital means? And then the therapeutical side, are there opportunities for actual digital therapeutics that are scientific evidence-based?
So I'll keep going. So the digital diagnostics are fantastic. I mean, we work with companies that use AI to interpret X-rays or over imaging, and you can see things in images that you wouldn't see with a traditional means. And you can diagnose the patients much more easily, and they come out with numbers 97, 99% accurate recommendation looking at an image. So diagnostics for sure are making incredible progress. On the therapeutic side, with Dario Health from the last 3.5 years I've been with them, we've seen a lot of progress as well, and we became a participant of the Digital Therapeutics Alliance that was founded 2 years ago, and that has the goal of making the digital therapeutics at the same level as drugs, essentially. And I remember a meeting we had at the US Pharmacopoeia, which itself was founded by an act of Congress to regulate drugs and eliminate snake oil and all the fakes that could have been circulating at the time, and make sure that drugs were of quality, reproducible, could be trusted. We are back to trust and everything. And now both the US Pharmacopoeia, Digital Therapeutics Alliance want to do the same. These digital therapeutics have to be trusted like drugs, which means they have to be reproducible with good quality, but you get what you expect when you open the package or you open your app, that they are effective and you demonstrate effectiveness by clinical trials, and they are safe. Now, safe is probably not an issue in many cases. When you start dealing with mental health and the large part of intervention is an interaction with an app, a system, an AI system, then it becomes essential. We obviously don't want to do any damage to the patient. So we see these standards coming up very strongly, and companies adhering to them. At some point, I guess there will be some kind of seal of quality that, yes, you can trust it, like consumer reviews. Yes, you can trust this app because it has been certified and clinically proven.
So the key is really the quality of the science behind the diagnostics and the therapeutics. Dr. Affan, from a physician's perspective, what's your point of view on the future of digitized diagnostics and therapeutics?
Yeah, I think this is inevitable. That's going to be the direction how we're all moving towards this. I recall I've been to a couple of exhibitions, or I can say conferences by Apple, and I saw how Apple as a company is moving forward with amazing way of putting all data together and getting into the digital diagnostics. So I think this is something that we have to accept. This is the evolution. This is how medicine, the precision of medicine, is going to go that direction. A lot of providers, physicians on my side, they are a little bit worried about how, whether this is IA or digitalization in general would eliminate jobs in healthcare or make it to be like, a replacement. As a matter of fact, we look at it on a different way, that we're getting more into a help and use the confidence of the science and the receivers of the services, whether the patients or in our case it's the children and kids and their families, when they know that we're using technology, but behind that technology there are people and scientists who are supporting that, exactly like when we use a technology in an aeroplane and there is a pilot, it makes a huge difference. But I think this is the revolution. This is the way the direction of healthcare is moving to.
So Tim, the US is just getting started, right? There are a lot of startups in the US, at least, around this notion of digital therapeutics. There's an intense debate about the veracity and quality of the science behind it. I mean, we've seen cases certainly in smoking and mental health. That's probably the two areas where the science is best in terms of actual therapeutic documented effect. Is the rest of the world in a different place, further along, and about the same place, not even discussing it? What's your perspective?
Yeah, it's very interesting. So, you know, you think about some of the companies that Rock Ventures and similar kind of you know, funds have backed in relation to sort of quotes digital drugs, hypertension, you know, chronic disease management and so on. You do of course see similar businesses beginning to, well, I mean, not just beginning, but being widely available around the world. I think and certainly there are instances, and I won't give particular examples here, but there are instances of particular narrow businesses that are in a way competing against standards, kind of conventional pharmacological interventions, using digital coaching or similar approaches to try and demonstrate outcomes that are better than the conventional, you know, the conventional medical or clinical approach. I think the way I think about this, which I think is a really important future kind of dimension, is when we talk about digital therapeutics, I think we need to be quite expansive in the way we think about that. So I think the digital therapy that's going to be most important is that enables really effective home care to facilitate people who otherwise would be in hospital to be treated in their normal place of residence. We've just seen COVID pretty brutally expose the weaknesses of our conventional approach to aged care in most countries, and unfortunately reveal that, you know, for the most vulnerable in the context of a pandemic, they can also be the least safe as we congregate people in special facilities that naturally make them more exposed to infection than perhaps if they were able to isolate more individually, if that was appropriate for their care and need. And there's a vast, you know, a whole army of businesses providing different approaches to kind of remote monitoring in different ways to support people at home. And I think if we think about digital therapeutics involving effective, proven means by which we can actually genuinely manage effectively people in their normal place of residence more effectively than being in hospital, that I think is going to be the breakthrough new model of care for most international health economies. That's certainly where most policy focus currently is looking at just how can technologies that are freely available be embedded in ways that make sense to clinical practice to reduce dependency on hospitals and aged care facilities in a way that will keep people safe, particularly in the context of COVID, but also more broadly just enable new ways of thinking about care provision outside the bricks and mortar institutions we've become used to.
Very interesting. I've been monitoring the chat, and there aren't a whole lot of other questions out there. So I encourage everyone to drop questions in the chat or in the Q&A section, but the chat preferably. It looks like we got time for one more quick round, right? So taking off on where you left off, how about research, and in particular clinical trials? How does that work out in this hybrid world we're talking about, where we're pushing the boundaries between in-facility outpatient and in your home? There has to be an angle that's related to clinical research.
Yeah, well, look, let me take that. So I think this is the most important, in a way, the most important component of this emerging landscape in which we live. So the acceleration that COVID has provided for digital health enables a kind of democratization of the clinical trials environment where we can all be involved in trials in a way that hasn't been possible before. And the precision medicine, the arrival of molecular diagnostics, essentially the way in which medicine is inviting us all into a conversation with our molecules that is unprecedented and enabled by digital health also means that we, with all our very unique attributes and vulnerabilities when it comes to disease, can and should be able to participate in very narrow clinical trials that are happening all the time and are just a routine part of clinical practice, that drug discovery, medicine's discovery is taking place in the context of real world evidence that is in fact us being in charge of our digital selves and being able to contribute those digital personalities to the broader benefit of research and medicine. And I do think that's going to be the long-term legacy of digital health. We think today in terms of interoperability and data analytics, but the future is really all about us being able to donate ourselves to research and science in a way that simply hasn't been possible before, and to determine, frankly, which molecules we are prepared to share with other people and researchers. And so a whole shift in the social license in which we make the decisions about what we share with other people in a way that I think will produce public confidence, but really revolutionize and democratize, if I can use that word, just provide us all with the opportunity to participate in research that will ultimately advance all our health and well-being, individually.
It's very exciting. Dr. Affan, research, digital, in pediatrics, your point of view?
Yeah, I think, I would echo with what Tim just said now. Decentralization is the big thing. Outreach is going to be much bigger, and the precision, as I mentioned earlier, those are all components that research is going to benefit from the digitalization. So I think this is going to advance, science, advance research in the future. And in pediatrics, trials for immunization going all around the world right now, and be able to do more and get more sample size because of this digitalization, and more precision.
Olivier, finally, your point of view on that.
There is what you are looking for, which is clinical research, and there is what you are not looking for, which is even more interesting in some cases. So with Dario, for example, we started to realize that people react extremely differently to insulin, and different types of insulin. Same person, different insulin, different person, same insulin. And we had no way to prove anything. We just realized, looking at tens of thousands of patients, that there are these differences. So what we find very interesting, and we are looking at different collaborations, but is putting 4 pieces of data together. One is the interventions that are done. You have a personal coach, a digital coach, whatever. 2 is the diagnostics, imaging or whatever diagnostics. 3 is what you measure from your digital data, the sensor you have on you, the data that you enter on your app, and so on. And 4 is genetics. And then you are going to have a lot of information, petabytes, that you will have to sift through and find the right information. But you are going to discover new things. And it's really probably going to be a huge enabler for personalized medicine or precision medicine, which is now you're going to understand that this person with this background, in this environment, with this genetics, submitted to this treatment, will have this kind of reaction. And there are so many mysteries today that we cannot solve, that hopefully putting all this data together, we are going to start finding new things. We tried 10 years ago with cancer patients and trying to see what is the correlation between number of variables. Now you can do much more than one study. You have entire millions of population and petabytes of data to work with.
So, final thought, Olivier, what would be your one-line catchphrase that you want people to leave this session with?
As an engineer, I'm excited, obviously, by technology. It's here to stay. It's here to keep improving. It's here to serve us. I think we should be concerned with AI, but not over-concerned. We have to make it in a way that it can serve us. But we always have to keep the human in the middle of it. As Dr. Affan was saying, knowing for a parent that there is a doctor behind, a human doctor, or if I know that in case of issue with my app, I can call a human coach and get a real human advice, will always be important.
And Dr. Affan, your headline for what you think this all means and what you want people to take away?
I think that, healthcare is in a catch-up, era and time for technology and digitalization. We are very much behind other sectors when it comes to, banking, economy, other sectors that have been way ahead of us. So it's time for us to catch. It's time for us to use technology to provide better services and more precise, using the science for our own patients. So I hope that we will accelerate all of us as stakeholders.
Tim, your final thoughts?
Well, just to echo Dr. Affan's comments, I think, in most health systems around the world, the background noise still remains the hum and whir of the fax machine. And we need to recognize that whilst we can talk bravely about the future of molecular diagnostics, that is our first priority. We need to axe the fax. That is a symbolic and important reality where none of these benefits can be realized unless we, and I don't mean just this generation, I mean right here, right now, in the next 2 or 3 years, we finally have to, after probably 2 decades, certainly in my experience, of discussion and goodwill and working really hard to get the job done has not been achieved. And we now really need to put in place the digital foundations, which will enable at least a modicum of working interoperability to begin to be able to take advantage of some of the benefits that, as Dr. Affan says, other industries now benefit from enormously, that will underpin our ability to offer some of these new medical sciences to patients. And I do on that basis think that this isn't just about us, it is about our children and their children. And we need to look towards the generational responsibility we have to finally deal with what are still very difficult issues. Just simply agreeing to a common identifier for patients in a country is not a small undertaking, but these are the kinds of difficult decisions we have to now conquer in order to enable the kind of safe, secure connections that will deliver the future that we've just been talking about.
And perhaps I take off from that for my own final comment was I've learned the hard way, and I tell my own team this all the time, right? Digital transformation is a journey. It is not a destination. Yes, the train has left the station, but it's not like it's going to arrive at some other station. Even when we hit all the kind of targets that the 4 of us have talked about during this session, there will always be something else, right? Because technology continues to move forward. So we're just at the very beginning of what I would call the digital age in healthcare. There is so much more to come, but to the point you just made, Tim, none of that is going to happen unless we want it to. And we collectively, everybody who works in healthcare, come together and make it so. So let that be my final comment. I thank my fellow panelists for your great insights and for a good, robust discussion. I hope everybody who was listening in enjoyed it and that we answered all your questions. Thank you very much. Back to Ransel and Kettering.
Well, thank you so much, Klaus. I'll tell you, you're like a treasure, and it was a lot of learning even internally here, but I can't thank you enough for a great session, and a great thanks also for the panelists Tim, Ashraf and Olivier for their great work. I'll pass it back on to Ransel. Thank you.